So the question is, what is the optimal bearing surface for the very young patient, which is still a difficult question to answer. These are my disclosure, not really related to this topic. And the question is important because wear and the consequent osteolysis are still the major causes of late failure. When we look at the reason for the risk of revision in the long time, the younger population are the higher at risk because of this reason. And that's because the reason of revision is age-dependent. We must be aware that the younger population is at higher risk of revision because of osteolysis and because of wear, while the older population are at higher risk because of periprosthetic fracture and dislocation. So this means a different approach in these two categories of patients. And we are operating more and more younger patients. These are my department in the last more than 30 years. You can see that the average age doesn't change too much. But that's because we are operating more and more people over the age of 90 even, and younger patients, which are now 5.7% younger than 40. And this is a database from the infantile group in the US, and the mean age of 17.1 years, the annual number of total arthroplasty performed is increased by 169% in this decade per year. So tribology is an important issue, but we have to recognize that there is very limited evidence, and there is no difference in the short to mid-term survivorship in randomized controlled trials when we compare ceramic on ceramic, ceramic on cross-linked poly, and metal on cross-linked poly. We all know that we are taking out metal on metal, so all the others can show similar things. But anyway, we see huge differences among countries. This is Europe. You can see that in Germany, they have a huge amount of ceramic on ceramic or ceramic on poly. A country which is very close to that, Denmark, they have a very poor use of it. They use metal on poly. The trend in the US, in the younger age, in these decades again, you can see a huge increase of ceramic on poly, somehow similar, maybe lower now, with ceramic on ceramic, a decrease on metal on poly. And when we go again to the same study with a very young population, you can see a huge increase of ceramic on poly and a decrease on ceramic on ceramic. So is that reasonable? Is that based on evidence? We don't know yet. What it was for sure the change of the game was the introduction of the cross-linked poly, which is no doubt the difference, huge difference about the conventional poly. We all discuss about poly, wear, and whatever, but we are discussing about the old conventional poly. So cross-linked poly is a different story, of course. And now, not in the last years, but now, we are moving to medium to long-term results. So now we can discuss to long-term results, 20-year results, with the young population with good survivorship in both components. So we must be aware at the point that we are about this topic. And when we look at the reason for failure because of cross-linked poly, you can see that the lysis is very, very poor. And to be honest, I never revised a patient because of lysis of cross-linked poly until now. Cross-linked poly improved the wear resistance, made possible the use of larger heads, improving the joint stability. We could move from 32 and 36, even 40, which was not personally suggested by me in this. But a minimum thickness of poly must be preserved, at least for this young group of population, 5 millimeters, because the cross-linking decreases the mechanical properties, and it's also a matter of design. Of course, when we have the possibility to choose, and we have to balance the two main problems and reason for failure, which is for the old population, dislocation. For the young one is long-term survival of the implant. We have to balance, probably using thicker poly for the younger, bigger heads for the older, which is reasonable. And we have seen breakage of cross-linked poly liners, especially with steep caps, with elevated rims, and bed locking mechanisms. Vitamin E reduces the oxidation in vivo. It improved the mechanical strength, which was the weak point, as mentioned before. There are promising, but with the vitamin E, we are at medium-term results. And with low wear for 36, and studies showing a lower risk of revision due to polyethylene-related endpoints. So this is one part of the story. The other part is the head. The head can be metal, can be ceramic. And again, there is no evidence in long-term studies about the volumetric wear compare the two possibilities. But we must be aware that there is at least the same, but usually better results when we consider the ceramic heads, never worse. And there is some advantages using ceramic. Ceramic has a higher hardness. It cannot be scratched, so there is less risk of damage during insertion. The surface finishing has only negative roughness. That means no deformation, so less risk of damaging of the liner. Better wettability, that's a better lubrication, and above all, highest bioinertness. We know about the problem of the trunionosis. There are some concerns about the trunion with the metal head. It is not strictly related to the head size in many times where there are no clinical reports with ceramic heads. Probably this is an overestimated problem. It accounts less than 2% of our revision, but it can be a problem because when it happens, it's a disaster. This is a 36 millimeter head, a cross-limb poly, and this trunionosis destroyed completely the epimassus in this post-rotator approach, and this patient started to dislocate few years after surgery. Or when big heads were used on small trunions, on small cones, that's when we also observe some gross staple failure in metal or cross-limb poly, and again, of course, this is a disaster. So what are the disadvantages, really, of ceramic on poly? The only problem could be the cost, because the risk of breakage is occasional, is insignificant in combination with poly. And to be honest, I can tell you that in my institution, in the last years, we have the metal heads at the same price of the ceramic heads, so you can discuss with the companies through your administration. There are areas in some part of the world, north of Italy, Korea, some other countries, where they have a huge use of ceramic on ceramic, and they have good performance when they combine of them. We are speaking now about the next possibility with this ceramic on ceramic. We have good clinical results in the long term with ceramic on ceramic. Again, long-term results when we use this combination, but ceramic evolved. They are not all the same. We had the biologs at the beginning, the biologs forward, and then since 20 years we have the delta with the interposition of small zirconium particles. So sometimes we are mixing ceramics, we are discussing different and mixing apple with oranges, and when this data, for example, which is from a regional registry in the north of Italy, and when they compare the delta on delta compared to other ceramic on ceramic, they had better results. And the better results with ceramic comes especially when you use 36 millimeter heads. So you have also to consider this. But again, there is another problem, which is the main problem when you use ceramic on ceramic, which is not the ceramic itself. It's the metal back, the shell deformation in thin press fit caps, which depends on the bone quality, on the instruments that you use, on the surgical technique. A minimum thickness of the metal back must be preserved. The fracture rate nowadays is very, very low. It is never related to trauma. We cannot say never, but nearly never related to trauma. It's linked to misalignment during insertion or because of metal back damage or cap malposition. This is the main reason for failure. Impingement and danger lodging, mainly due to antiversion. And I come back to the story. There are some systems, some implants that were developed, especially in Europe for ceramics. They have good tools for implantation. It's very easy when you go with the ceramic inside the metal bag. There are some others that are quite primitive. You have wonderful metal bags with good high porosity, but poor tools for implanting. And then you have poor ceramic. Some of these systems were developed for cross-limb poly. So when you use ceramic, you can have some difficulties. And again, the problem of positioning, these are some of our retrievals. In all these cases, you can see that on the opposite side of the breakage, there is the black stripe, which means impingement against the neck. This leads to a possible contraindication for ceramic or ceramic also in the young patient, because in case of severe DTH, post-traumatic acetabular, when it can be difficult to reach the correct orientation, the correct offset, or whatever, because due to local anatomy, ceramic can be dangerous. And patients showing weakness of the pelvic muscle, soft tissue toxicity, the hypermobility, the Richard labs, and the excessive range of motion can be considered a risk when you use ceramic on ceramic. Then we have the problem of squeaking. From my point of view, this is a minor problem. It has a multifactorial origin. You know, it's strictly linked to some implants where they have a huge amount of squeakers. But you know, this was the implant. This was a bad implant. And the outcome and patient satisfaction are not affected. So this is not the main reason for deciding one or the other. So in conclusion, what is the optimal bearing surface for the young patient nowadays? Not in the past, not in the future. To be honest, we don't know yet, as there is a lack of long-term studies. With ceramic on ceramic, and also you have to consider the diameter, 32 or 36, for the higher wear resistance, the biocompatibility is attractive. But ceramic on cross-linked poly with 28 or 32 maybe in the young population is okay, and there is a trend in use toward this type of coupling. But ceramic has changed, metal backs are not all the same, cross-linked poly has changed, and they are not all the same. So the next decades will confirm this hypothesis. And what makes really the difference is the correct surgical technique, the handling on the components, positioning of the implant, and be aware that the young patient is more sensitive even to small defects. Let me finish. Thank you, all of you, for your attention, and also to my mentor, Roberto Giacometti. He was here since the beginning of the first burn courses. He was faculty for many years. He passed away 3 weeks ago. Thank you very much for your attention.